Hello, my name is Angela Craig, and I'm here today to talk to you about the Rossiter study. And this is Articles with Angela. As far as my disclosures, I am a senior manager with Baxter Medical Affairs, and I do have some financial disclosures. I am still a clinical nurse specialist with critical care at Cookeville Regional Medical Center, Cookeville, Tennessee. I'm an independent consultant PRN, and I'm also a Sepsis Alliance Advisory Board member. So let's talk about a recent study that has shown mortality benefit of stroke volume guided care in the rapid response. This particular study I call the Rossiter study, but the title is A Service Evaluation of Measuring Fluid Responsiveness in Acutely Unwell Hypotensive Patients Outside of Critical Care. So let's talk about some background. We know that early recognition and prompt appropriate management of patients may reduce mortality in sepsis. We also know that the Surviving Sepsis campaign suggests using dynamic assessments to guide fluid resuscitation in sepsis, but yet it should be noted that most use of cardiac output monitoring was and has been in the ICUs. So in this particular study, they wanted to introduce the use of a goal-directed fluid management protocol into their critical care outreach team's standard clinical assessment. Now, this evaluation was done at a 520-bed medium-sized district general hospital, and they had 28 beds in their ICU, which deals with caseload of surgical and medical patients. They have a critical care outreach team, and they call that the CCOT, from 8 o'clock in the morning until midnight, 7 days a week. Now, these were highly trained nursing staff who can provide ICU level care in general hospital wards and also emergency departments. And this group is called to assess deteriorating patients outside of the ICU. So, as far as interventions, there were adult patients with hypotension, and the criteria was blood pressure less than 90, and they were reviewed by the CCOT team and were considered for inclusion. Now, inclusion criteria was that they had to be an adult, that they had to have a systolic blood pressure of less than or equal to 90, and had to have fluid therapy be considered a reasonable first-line approach by clinicians. And by the way, this particular study, this paper was published in the UK. The pre-implementation phase, the CCOT collected data on sequential patients with no additional interventions. So basically they had two arms, right? They had the patients that they just did, that they took care of the standard way, and then they had patients that they started utilizing bioreactance technology on when they would go to these rapid response events. So there were two groups, the pre-bioreactance group and the post-bioreactance group. And as you can see, very similar. I will say the post-bioreactance group had a little less blood pressure and mean arterial pressure that was statistically significant. And so you can see if they were suitable, they met the criteria for moving forward with goal-directed fluid therapy, then they would go ahead and start a bolus. They would give a fluid bolus and determine if they were fluid responsive. If they were not fluid responsive, they would consider other treatment for hypotension. So let's look at some of the outcomes of this study. As you can see over on the left, the post-bioreactance group had less fluid that was given in the first 6 hours, and that was statistically significant. As well, you're going to see some statistical significance in the number requiring RRT. There was 0 requiring that in the post-bioreactance group. There was 0 requiring IMV or mechanical ventilation in the post-bioreactance group, and there was 0 requiring vent BiPAP or CPAP in the post-bioreactance group. And there was no statistical significance to days to hospital discharge in either of the groups. So let's talk for a second about reporting mortality, absolute versus relative. So the absolute reduction means that there equals an actual difference between both groups. Relative reduction means a percentage of change relative to the control group. So those are just a little bit different. But I also want to mention that this is not a randomized control trial. It was not weighted to determine causality. There really weren't enough patients. And there was variability between the two cohorts. That second group was more acutely ill. There was an increased use of vasopressors. And we did see, though, a significant reduction in the need for RRT, for mechanical ventilation, and BiPAP. And so what we found was that this study was very similar to what has been shown in the KU, FRESH, and Premier Health database. So let's talk about a take-home for this study and implications for clinical practice. So adoption of dynamic measures of cardiac output and stroke volume outside of critical care by trained critical care nurses is feasible and may translate into improved patient outcomes. Non-invasive bioreactance monitoring provides dynamic assessment of fluid responsiveness quickly and accurately. It enables personalized fluid therapy and takes the guesswork out of fluid administration. And it can be used across all care settings. Here is the reference for the study that we just discussed. I just want to say thank you for your time. And if anyone has any questions or wants to reach out to me, my email address is angela_craig@baxter.com. And I hope you've enjoyed this article with Angela.